So continuing myelodysplastic syndrome, so the laboratory studies. In laboratory studies, anemia is present in most cases. So it is either present alone. So if you do a peripheral smear, so it will be a bi or pancytopenia, and isolated neutropenia. It is more unusual. And macrocytosis. So this is common as in most marrow failure disease. So even macrocytosis is also common as in most marrow failure disease. So platelets, no, say they are large and platelets lack granules. However, the platelets are large and they lack the granules. In functional studies, platelets may show marked abnormalities, and patients may have bleeding symptoms despite adequately normal numbers. So though the numbers are adequate, but patient may have bleeding symptoms. If we take neutrophils, so these neutrophils are hypogranulated. Neutrophils are hypogranulated, have hyposegmented, ringed or abnormally segmented nuclei. So how are the neutrophils? Hypogranulated, hyposegmented, ringed or abnormally segmented nuclei. So these neutrophils, they contain Dolly bodies and they may be functionally deficient. Neutrophils are hypogranulated, hyposegmented, ringed or abnormally segmented nuclei. So they contain Dolly bodies and may be functionally deficient. Circulating myeloblasts usually correlate with marrow blast numbers. So if more blast in the marrow, so even circulating myeloblasts will be more, and their quantity is important for classification and prognosis. So the more number of blasts, the poorer the prognosis. So the total white blood cell count is usually normal or low except in CMML. Okay, total white blood cell count is usually normal or low. As in aplastic anemia, so this aplastic anemia will be associated with PNH. In the same way, MDS can also be associated with a clonal population of PNH cells. Even MDS also associated with clonal population of PNH cells. So genetic testing is commercially available for constitutional syndromes. Bone marrow. So if we take bone marrow, so this was all in the blood. Okay, anemia will be there, macrocytosis is there, platelets lack granules, and neutrophils are hypogranulated, Dolly bodies. White blood cell count is usually normal or low except in CMML, and even clonal population of PNS cells can be seen in MDS like in aplastic anemia. So bone marrow is usually normal or hypercellular. It's hypercellular, normal or high, but in 20% of the cases, no, it is sufficiently hypocellular. So this will lead to confusion with aplastic anemia, because aplastic anemia is also hypocellular. Only in 20% of the cases it is hypocellular, leading to confusion with aplastic anemia. So no single characteristic feature of marrow morphology distinguishes MDS, but the following are commonly observed. So dyserythropoietic changes. So no single characteristic of marrow morphology distinguishes MDS. No single characteristic feature distinguishes MDS, but the following are commonly observed. So dyserythropoietic changes, especially nuclear abnormalities and ringed sideroblast in the erythroid lineage. What should be there? Dyserythropoietic changes, especially the nuclear abnormalities and ringed sideroblast in the erythroid lineage, hypogranulation and hyposegmentation in granulocytic precursors, hypogranulation and hyposegmentation with an increase in the myeloblast and megakaryocytes megakaryocytes showing reduced numbers of disorganized nuclei. Megakaryocytes showing reduced number of disorganized nuclei. Megaloblastic nuclei and defective hemoglobinization in the erythroid lineage are common. In the erythroid lineage, megaloblastic nuclei and defective hemoglobinization in the erythroid lineage are common. Prognosis, it strongly correlates with proportion of marrow blast. So more number of marrow blasts, the prognosis is poor. So this should be enumerated on the marrow smear and by flow cytometry of an aspirate. And this flow cytometry can also reveal characteristically aberrant hematopoietic differentiation. And cytogenetics and FISH, they can identify the chromosomal abnormalities. Differential diagnosis. So deficiencies of vitamin B12 or folate should be excluded by appropriate blood test. Vitamin B12 or folate deficiency because of macrocytosis, they should be excluded. And vitamin B6 deficiency, so this can be assessed by a therapeutic trial of pyridoxine if the bone marrow shows ringed sideroblast. So bone marrow is showing ring sideroblast, so patient can be given a therapeutic trial of pyridoxine. So copper deficiency can lead to cytopenias and dysplastic marrows. So even the copper deficiency, so this can also lead to cytopenias and dysplastic marrows of varying cellularity. So marrow dysplasia, so this can also be observed in acute viral infections, drug reactions or chemical toxicity, but it should be transient. So even marrow dysplasia, so this can also be seen in acute viral infections, drug reactions or chemical toxicity, but this should be transient, that is it should subside after few days. And more difficult or the distinction between hypocellular MDS and aplasia, whether it is aplastic anemia or whether it is hypocellular MDS, and between refractory anemia with excess blast and acute leukemia. So this because the WHO considers 20% blast in the marrow as a criteria that separate AML from MDS. So MDS 5 to 90%. So if it is 20% blast, so this separates AML from MDS. So in young patients, underlying predisposing genetic diseases should be considered an appropriate genomic testing. So the median survival varies greatly from years for patients with 5q minus or sideroblastic anemia to a few months in see if there are excess blast, what will be the median survival? It will only be a few months with excess blast, or if there is severe pancytopenia associated with monosomy 7. So if it is 5q minus or sideroblastic anemia, patient can live for years, but if there is a refractory anemia with excess blast or severe pancytopenia associated with monosomy 7, so then the survival, it will reduce to few months. So the International Prognostic Scoring System, so this was revised in 2012. International Prognostic Scoring System assist in making prediction. So even lower risk MDS, no, so this has got significant morbidity and mortality. And so the outlook in therapy related MDS regardless of type is extremely poor, and most patients progress within a few months to refractory AML. Patient would have taken some chemotherapy. So this therapy related MDS regardless of type, the outlook is extremely poor, and most patients progress within a few months to refractory AML. So what are this? So this revised international prognostic scoring system, so based on blast, based on cytogenetic abnormalities, based on depth of cytopenias, and inclusion of the differentiating features, age, performance status, serum ferritin, LDH, beta 2 microglobulin, and prognostic model with 5 versus 4 risk categories and improved predictive power. Depth of cytopenias means cytopenias at baseline, cut points, hemoglobin less than 8 or platelet count less than 50,000 or absolute neutrophil count less than 800. See, good, normal, so these are deletion 5q, deletion 20q. Poor complex is greater than or equal to 3 abnormalities, or chromosome 7 abnormalities. So this is the revised international prognostic scoring system. Intermediate means all other abnormalities. If it is poor means poor or complex means greater than 3 abnormalities or chromosome 7 abnormalities. So it is categorized under poor. Good means normal, minus 5 minus y deletion 5q deletion 20q. So treatment. So therapy of MDS, no, so this has been unsatisfactory. But several drugs may not only improve blood counts, but they also delay onset of leukemia and improve survival. Treatment is unsatisfactory, but several drugs are there. They improve blood counts and they also delay the onset of leukemia and improve survival. So the choice of therapy for an individual patient, administration of treatment and management of toxicities are complicated and require hematological expertise. Only which offers cure for MDS? Only hematopoietic stem cell transplantation. So this offers cure of MDS. So the survival rate in selected patient cohorts is 50% at 3 years but improving. So results using unrelated matched donors. So this is similar to those of siblings. So after bone marrow transplantation, so even though unrelated matched donors, the results are similar to those of using the matched transplantation from the siblings. And patients even in 50s and older, so they also have been successfully transplanted. Nevertheless, treatment related mortality and morbidity increase with recipient age. As the recipient's age increases, treatment related morbidity and mortality also increases. So the transplant conundrum is that high risk patient by IPSS score and presence of monosomal karyotype for whom the procedure is most obviously indicated. See, if the score, prognostic score, if it is high and presence of monosomal karyotype, see, in this high risk patient, obviously therapy is indicated, procedure is indicated, but at the same time, poor outcome also occurs because of transplant related mortality or disease relapse, whereas the low risk patient who is more likely to tolerate transplant, they also may do well for years with less aggressive therapies. In practice, only a small proportion of MDS patients undergo transplantation. So in practice, only a small proportion. So MDS has been regarded as particularly refractory to cytotoxic chemotherapy regimens. And as an AML in the older adult, drug toxicity is frequent and often fatal, and remissions if achieved are brief. So MDS, no, so this is refractory to cytotoxic chemotherapy regimens, and as an AML in the older adult, drug toxicity is frequent and it is often fatal, and remissions if achieved or brief remissions. So low doses of cytotoxic drugs have been administered for their differentiation potential, and from this experience, drug therapies have emerged based on pyrimidine analogs. So these drugs are classified as epigenetic modulators believed to act through a demethylating mechanism to alter gene regulation and allow differentiation to mature blood cells from the abnormal MDS stem cell. So low doses of cytotoxic drugs. So low doses have been administered for their differentiation potential. So, and from this experience, so from the use of low doses of cytotoxic drugs for differentiation potential, so drug therapies have emerged based on pyrimidine analogs. So these drugs are classified as epigenetic modulators. That is, they are believed to act through a demethylating mechanism to alter the gene regulation and allow the differentiation to mature blood cells from the abnormal MDS stem cell. The hypomethylating agents azacitidine and decitabine are frequently used. So what are the hypomethylating agents which are frequently used? So these are azacitidine and decitabine. Azacitidine improves blood counts and survival in MDS compared to best supportive care. So if it is supportive care or use of azacitidine, it is obviously azacitidine. So because of giving azacitidine, it improves the blood counts and survival in MDS. So this azacitidine, it is usually administered subcutaneously daily for 7 days at 4-week intervals for at least 4 cycles before assessing for the response. So before assessing response with azacitidine, at least this drug has to be given for 4 cycles. So daily for 7 days at 4-week intervals. Okay, 7 days, 4-week intervals and 4 cycles. Overall, generally improved blood counts with a decrease in transfusion requirements occurred in 50% of patients in published trials. So generally, overall what happens, there will be improved blood counts with a decrease in the transfusion requirements. So response is dependent on continued drug administration, and most patients eventually they become refractory to drug intervention and experience recurrent cytopenias or progression to AML. If there is a drug interruption, so what will happen, patients will become refractory to drug. If there is continuous usage of drug, patient may become refractory to drug and they experience recurrent cytopenias or progression to AML. And decitabine, so this is closely related to azacitidine. Then we have this decitabine. So this is closely related to azacitidine. 30 to 50% of the patients show response in blood counts with a duration of response of almost a year. So with decitabine, which is closely related to azacitidine, 30 to 50% of patients they show response in blood counts and the duration of response is almost a year. So this decitabine, so this is administered by continuous intravenous infusion in regimens of varying doses and duration of 3 to 10 days in repeating cycles. So this is given by continuous intravenous infusion. Major toxicity of azacitidine and decitabine is myelosuppression. What is a major toxicity? It is myelosuppression. So this drug can also lead to worsening of the blood counts. And then we have hypomethylating agents. So these are frequently used in the high risk patient who is not a candidate for stem cell transplant. So hypomethylating agents are frequently used in the high risk patient who is not a candidate for stem cell transplant. So in the lower risk patients, they are also effective, but alternative therapies should be considered. So even in the lower risk patient, they are also effective, but alternative therapies should be considered in lower risk patients. Lenalidomide, so this is a thalidomide derivative because of the more favorable toxicity profile. If we take this lenalidomide, so this is a thalidomide derivative, so this has got a more favorable toxicity profile. It is particularly effective in reversing anemia in MDS patients with 5q minus syndrome. So where is lenalidomide used? So lenalidomide is used in reversing anemia in MDS patient with 5q minus syndrome. So it is a thalidomide derivative. So lenalidomide has got a more favorable toxicity profile. Not only do a high proportion of these patients become, because of giving this lenalidomide, patients will become transfusion independent with normal or near normal hemoglobin levels. But the cytogenetics, so this also become normal. See, cytogenetics are becoming normal and hemoglobin levels are also becoming normal. So the drug has many biological activities and unclear which is critical for clinical efficacy. So this lenalidomide, so this has got many biological activities and it is unclear what is critical for clinical efficacy. So this is administered orally and most patients, they will improve within 3 months of initiating therapy. So if we give lenalidomide, most patients improve within 3 months. So what are the toxicities? Myelosuppression, that is worsening of the thrombocytopenia and neutropenia, necessitating blood count monitoring, and there is also an increased risk of deep vein thrombosis and pulmonary embolism. So what are the toxicities of lenalidomide? Myelosuppression, worsening thrombocytopenia, neutropenia, necessitating blood count monitoring, and there is also increased risk of DVT and pulmonary embolism. And immunosuppression, so this also may produce independence for transfusion and improved survival. Apart from this, we can also give immunosuppression. So what can we give? ATG, anti-thymocyte globulin, cyclosporin, and anti-CD52 monoclonal antibody alemtuzumab. So these are especially effective in younger MDS patients. Younger means less than 60 years old with more favorable prognostic score. So immunosuppression, so this also produces independence from transfusion, and this also causes improved survival. So what is given? ATG, anti-thymocyte globulin, cyclosporin, and anti-CD52 monoclonal antibody. So this is alemtuzumab. So these are especially effective in younger MDS patients with more favorable risk scoring system. So in a consortium retrospective review, about 50% of patients with mainly refractory anemia responded to ATG, usually combined with cyclosporin, particularly patients with hypocellular marrow. Supposing patients are having hypocellular marrow, so what is given? ATG, it is usually combined with cyclosporin, and it is given to those patients who are mainly having this refractory anemia. So these patients, 50% patients have responded. And hematopoietic growth factors can improve blood counts, but as in most other marrow failure states, they have been most beneficial to patients with least severe pancytopenia. So this erythropoietin and colony stimulating factors, they can improve blood counts, but as in most other marrow failure states, they are most beneficial to patients with the least severe pancytopenia. Erythropoietin alone or in combination with granulocyte colony stimulating factor, they can improve hemoglobin levels, particularly in those with low serum erythropoietin levels are there, then we can give this erythropoietin. And so because of giving this erythropoietin, survival may be enhanced, and there should be amelioration of anemia. And granulocyte CSF treatment alone failed to improve survival in a controlled trial. So if this only colony stimulating factors, it alone failed to improve survival. And thrombopoietin mimetics appear to improve platelet counts in some MDS patients, with no clear evidence that they increase the rate of leukemic transformation. So then we have this thrombopoietin mimetics. So they also appear to improve platelet counts. And newer drugs for MDS are entering the clinic or in late development. So the newer drugs are in the development stage. Then we have this luspatercept. Okay, what is this? Luspatercept. So this affects the transforming growth factor beta mediated suppression of erythropoiesis. So luspatercept, so this affects the transforming growth factor beta mediated suppression of erythropoiesis. So this has been approved by the FDA for anemia and MDS. And novel targeted TGF mediated suppression of erythropoiesis can be treated with luspatercept. So this affects transforming growth factor mediated suppression of erythropoiesis. Novel targeted therapies include inhibitors of hypoxia-inducible factor inhibitor, okay, and spliceosome genes. Drugs, TP53 is a tumor suppressor gene, so we have to restore TP53 activity. Drugs that act to restore TP53 activity. And venetoclax. So what is venetoclax? Inhibitor of the BCL2 protein. So it increases programmed cell death So this is approved for use or employed off-label. So venetoclax, it is a inhibitor of the BCL2. So this is for approved for use or employed off-label in other hematological malignancies, and the same principles of supportive care for aplastic anemia. So same supportive care, infection has to be treated, blood transfusions, and many patients will be anemic for years, and RBC transfusion support should be along with RBC transfusion. What else should be given? Iron chelation should be given to prevent secondary hemochromatosis. So along with RBC transfusion, what else should be given? Iron chelation should be given to prevent secondary hemochromatosis.